Now I request our next speaker, Dr. A. Baronia, Professor and HOD Critical Care, SGPGI, Lucknow. His topic will be Critical Care Quality and Safety, and I request Chairperson, Dr. Prakash, Professor Anesthesia, IGIMS, Dr. Ajay Sinha, Department of Medicine, NMCH, and Dr. V.K. Thakur, well-known physician.
Good afternoon. The next topic is going to be discussed by Professor A.K. Baronia from SGPGI, Lucknow. It is critical care ethics, quality and safety. A few words I want to share with you about Dr. Baronia. He is an alumni of King George, Lucknow, and he was the first senior resident to join Sanjay Gandhi. He was the first senior resident to join at SGPGI, Lucknow. And later on, when the Department of Critical Care Medicine separated from the Department of Anesthesiology, he became the first head professor and head of the department. Dr. Baronia has published many international papers, and he has also worked for some time in UK. And it is indeed an honor to invite him, my teacher, who was my teacher at SGPGI, to deliver his talk on this interesting topic.
Thank you, Dr. Deepak. Thank you, Dr. Kishore. And thanks for this introduction. Thank you, Dr. Dubey and all other chairpersons. Thank you very much. My topic is about the quality and safety in intensive care unit, and I spoke last evening to Dr. Deepak that I am not comfortable with the timing because it is exceeding the limit which is being set by the organizers. So they said that please continue with your talk, nobody will interrupt you. So thank you very much with that kind of I am obliged with that kind of your idea. So first and foremost thing that whenever I think about the quality and safety, I always feel that there is a gap between what we want to achieve and what we keep on thinking. That chasm is always perceptible. Sometimes it is very disturbing kind of chasm that we need to cross. So what are the basic problems in crossing the quality chasm? I believe that the quality and safety is not or has not been a part of our curriculum. They are never taught to us as a definitive subjects, either at the undergraduate level or at the postgraduate level. That might be one of the reasons why when we become consultants, we feel that we are unable to handle the subject properly at many times. Second point probably is that there is no glamour attached to the quality and safety as such. Professionalism we do exercise, but the quality and safety part is sometimes overlooked. Then the administrators and doctors do not sometimes take much interest in the subject of quality and safety. But I was very happy to listen from Dr. Deepak here that he was really concerned about this issue and he wanted something to do about the quality and safety in his own hospital. I do believe that there is not much of the appreciation or admiration to encourage the people to work for the quality and safety. And the research perhaps in this field is not done the way it should be done, because we believe that it is a waste of time and energy. We invest our time in research in some definitive subjects, not the abstract subjects like the quality and safety. Last but not the least is that whatever educational material comes to us on the subject of quality and safety, it comes from the West. And the Western infrastructure, I would say, first world infrastructure, they have worked hard to develop their healthcare infrastructure, which is way beyond what we have today in India. So their recommendations sometimes do not fit very well into the India, which is having a third world infrastructure. So these are the probably some of the problems that we face in crossing the quality chasm on our day-to-day basis. Now, coming first, that what are the possible aims that we look for in the quality improvement programs? I would first and foremost would say that the paradigm of quality is not to put the two things into the contrast like good and bad, but in fact it is a movement towards only one direction, that is from good to better to the best. And out of the 6 aims that I have put forth before here, safety always remains an integral part of the quality management programs. So these aims would be safety, effectiveness, equity or impartiality, timeliness, patient-centeredness and the efficiency. They are the goals or the aims which are generally accepted very well. And then what the quality is, by way of definition proposed by the Institute of Medicine way back in 1990, quality is the degree to which the healthcare services increase the likelihood of the desired health outcome, and those outcomes should be consistent with the current professional knowledge. So what is going to be the measure of quality? That comes the next question. Basically, it would be the kind of results and outcomes that we are having in our ICU against the objectives that we set forth. So there would be a numerator and there would be a denominator, and objectives, these objectives basically are, these objectives are another name that we can give to these objectives is the quality indicators. So coming to the quality indicators for ICU, the definition of quality indicator is basically quality indicator is an instrument of measuring the patient's presence or absence of any phenomenon, and then it's measuring its intensity. Basically the quality indicators would fall under 3 domains. One is the structure, second is the process, and third is the outcome. In the structure, what the structure means is basically what you need to perform well in the ICU versus what is available to you. It can be anything, it can be monitors, manpower, etc. So some of the examples of the structure related quality indicators would be closed versus open ICU, high intensity versus the low intensity staffing. Then comes the process, and under the process there are several indicators that can fall in this group. Process means what you should do versus what you actually do. So that difference is to be measured, and in that we have to basically stand with the international guidelines as a quality indicators. And the examples can be the web prevention strategies or the lung protective mechanical ventilation that we provide in the ICU. Third category of quality indicators fall in the category of outcomes, and that is what means that what you expect versus what you are actually getting as an outcome. And those outcome measures can be something like mortality or the cost of treatment, and even some morbidity indicators also. So our objectives of finding out any quality indicator that we want to work upon, our main objective should be to improve something, to enhance something, to ensure something good, and to change something which is not good, but never to put any blame on anybody or any of the infrastructural problems. So blame game is not the part of the quality improvement programs. Next thing that I thought of, that once you know that quality indicators are important to initiate any quality improvement program in the ICU, then how do we select the quality indicators for our own ICU, how we use them or how we implement them in our ICU, and then how do we interpret the results once we do some kind of interventions. So how to select the quality indicators? I would suggest to at least go with the Pareto principle, which is also known as the 80-20 rule or the law of the vital few. And this law states that many events, and particularly we are talking about the bad events over here, so roughly 80% of the effects come from the 20% of the causes, which means we have to identify those high frequency sort of factors. Say this is there are the various 8 factors which can increase the VAP in our ICU or ventilator pneumonia in our ICU. Then we have to choose these 3 factors rather than the other factors which are having very low frequency in the ICU. So this principle has to be followed while selecting the quality indicators for our own self. Now this has been a problem, and of late in 2012, this publication came in the intensive care medicine, and this was basically a study, not a study, but the work of the task force of European Society of Intensive Care Medicine, and they were trying to define the safety and quality indicators in a prospective manner, and they selected certain experts from the European countries who actually followed the Delphi process of communication, which is a structured communication technique to develop any kind of sort of expert opinion. So this group initially identified 111 indicators, and over a period of 1 year, after 5 rounds of discussions, they came down to 36 and 23, and finally they notified only 13 indicators which they considered very important for the ICU, and which had more than 75% of the consensus. Out of these 13, 9 actually had as good as 90% of the consensus in the group. So these 13 I like to narrate because they have been decided by international consensus group. First 3 fall into the structure domain, and out of these 3, one is that ICU should fulfill the standard requirement to provide intensive care infrastructure wise. Second is that there must be 24-hour availability of an ICU consultant in the ICU. Third is that there must be a system of adverse event reporting that must be in place. So these 3 things must be there in the ICU as far as the structure of the ICU is concerned. The next 4 indicators fall in the category of processes, and that includes the presence of a routine multidisciplinary clinical ward round that must take place on a day-to-day basis. Second is we must have the standardized handover takeover procedure for the patients so that the data loss is not there. Third is the maintenance of the continuing medical education activity that should be there, and then the maintenance of the bed occupancy rate below a threshold level should be regularly monitored. Out of the 6 other outcome measures which fall in the category of outcome, first one is the reporting and analysis of the standardized mortality ratio. Second is to keep a note of ICU readmission rate within 48 hours of the ICU discharge, and that should be less than 4%. Third one is the rate of catheter related bloodstream infection, and that should be less than 4 per 1000 CVC or central venous catheter days. Fourth one is the rate of unplanned endotracheal extubations, and that should be less than 10 per 1000 intubation days. Others are the rate of endotracheal reintubation within 48 hours of planned extubation, and the rate of VAP. For that they have not set forth any of the sort of quantitative figures. So how many indicators we can choose for our own ICU, that would be the next question. It can be 9 indicators, 13 indicators, 30 indicators, I do not know. Everybody has to work out for their own ICU, and it will depend on the willpower and the kind of resources that we have in our ICU, and also it will depend upon the current status of our ICU with regard to the safety and quality as per the international standards are there. So based on that, probably we have to decide for our own self what quality indicators we choose, and it is better to work on as many as quality indicators as possible, but I think it is better to also look at the other side, that you start with the few ones, you complete the cycle, and then probably go for some other quality indicators, and we can have that kind of ongoing program. Some indicators we work for 3 months, then we go for other indicators, then we go for other indicators, and that is how we can work it out. So it's just to complete that how many indicators are possible for an ICU. So structure wise or structure related quality indicators can be closed ICU model, intensivist led team, as I have told. Unit is conducting the regular audits. There is daily review of the management plan, and there is a hospital acquired infection surveillance system is there that can be within the structure related quality indicators. Out of the process related, they can be DVT, stress ulcer prophylaxis, VAP prevention study, central venous catheter related bloodstream infection or complication because of the placement of central venous catheters, and then protocol driven ventilator weaning. They can be the part of the process related quality indicators, as well as in the process falls the early and late sepsis management, whether it may be fluid or antibiotics or steroids. Then low tidal volume or lung protective mechanical ventilation in the ARDS, non-invasive ventilation as a first sort of management strategy for hypercapnic respiratory failure, whether we are doing that or not. Early enteral feeding, how much we are able to comply with that. Bad sore prevention strategies, appropriate transfusion thresholds, for all the blood products that should be checked, and that can be as a very good quality indicator for our ICU. Then what kind of palliative care we are able to provide, particularly the end of the life care. In the outcomes, it is, as I said, mortality is one of the important things, then unplanned extubation rates, VAP and CRBSI incidence rates, early discharges from the ICU, how quickly we can discharge, and then serious adverse drug event, multiple drug resistant organism that we have in ICU. All that should be discussed, must be discussed in the mortality meeting, so that should be there. Unit should have undertake the regular family experience surveys, how good the counseling is, whether the patient's family is satisfied with our care or not, and then unscheduled readmissions within 24-48 hours of discharge. So some of these indicators we can choose wherever we feel that we are a little not up to the mark, we can choose that indicator for our own ICU. Then how do we use or implement the quality indicators in our ICU? Basically, it is nothing but development of checklist and the audits. For every quality indicator or a group of quality indicators, like web prevention strategies, if there are suppose 5 things that we need to do, we have to have one checklist for that kind of thing. And then finally we have to conduct the audits, what kind of changes are taking place over a period of time with regard to the one or the other quality indicators. So what can be the checklist? Checklist can be for one individual patient, it can be for the entire ICU, or it can be for any of the processes. Now, to begin with, I think it is better to go for the checklist for the entire ICU. What we are doing, what we are not doing as our sort of entire ICU activity, that we can have a look on that. Then we can probably subsequently we can go for the checklist for the individual patients. But I'll just put up certain examples. They are nothing but checklist means checklist, nothing great about it. But like the web checklist can be the head and elevation, daily sedation, vacation, or daily assessment for the readiness to extubate, peptic ulcers, disease prophylaxis, DVT prophylaxis, and the one which is added as a 5th one is the new one in the last couple of years that has been added as a continuous aspiration of the subglottic secretions. So on the one patient we can have this checklist, and every day we can cross whatever we could follow or whatever we could not follow, and that can be one of the ways for the individual patients. Now the same thing can be done for the entire ICU, and here also again it is ventilator related sort of issue where you can add upon to the besides other thing, we can add upon to the routine care with the routine oral care with the chlorhexidine, or lastly but not leastly the management of delirium, and then trying to have some sedation scale in the ICU based on which you prescribe the medicines like midazolam and fentanyl, whether that. So you can arrive at a conclusion whether you have that particular activity in place or not, whether you are planning to do it in the future, whether you will adopt something on that issue, or some special notes. So that can be the initial survey that can be done for the entire ICU, just to find out what are our weaknesses. Then there can be a checklist for the patient handover takeover, so that we don't lose much of the data, and in which we can have almost each and everything that is being done to the patient, right from the lab results to the antibiotics and cultures, and any communication or consults that is to be done, all medications, all sort of IV infusions, and ABG, ventilator setting, respiratory treatment, everything can be there in the checklist. And then shift wise, when handover takeover is taking place, it has to be on some kind of written sort of documentation. If that is there, I'll tell you what is the benefit of that. So the actions taken in each shift can be something is checked, something is some new treatment is done, or some new order is coming up, something is being changed, something is being stopped, or some new contact is to be established with nephrologist or cardiologist or whatever it is. So the checklist that we choose for our own SGPGI is basically very small. It is having only the core elements of intensive care, and the core elements I picked up from the earlier publications that relates to the what we call as a fast hug and faith. And for the fast hug and faith, these are the components of fast hug and faith, that is the regular feeding, regular anxiety relief, Every day we have to have a sedation, intermittent sedation of the sedation, thromboprophylaxis on a regular basis, head and elevation, ulcer prophylaxis, glycemic control. The fluid balance is done every day, and cumulative fluid balance is also seen on day-to-day basis. So we, on a particular day on the clinical round, we don't have to say only the 24 hours fluid balance, but we have to see the cumulative fluid balance of last 3 days, 5 days, 6 days, 7 days. And then if and laxatives are to be given, whether it is being given or not, all investigations and results are being reviewed or not, new therapies are being consulted or not, and appropriate hydration is being given or not. So in our checklist, we would say yes or no to these things. Did we have a daily briefing about the fasting and faith on a particular patient? Yes, no. Whether the goals of the treatment are on the monitoring are known to everybody in the team? Yes or no. Whether everybody in the team understands what to do and what not to do. Whether everybody understands that what is the planned physiotherapy or other physiotherapy sessions. So their plan, time is noted down, and that is how we do it. And that clinical round completes with something that who is going to do what for the next 24 hours. So that kind of checklist we have, and we are very happy with that kind of checklist. Subsequently, I would say that once you have done a checklist program, then you will do the intervention, then you will have to do the audit and find out what are the changes in the practices. So this is one kind of audit result that I am just placing before you, published in Critical Care Medicine 2008. In this ICU, there was a perception in the ICU that they are following the low protective mechanical ventilation strategy. They are giving a tidal volume less than 6 mils per kg. So that was perceived when it was just asked, the questions were asked from the different people in the ICU. They thought that their adherence to the low tidal volume is as good as 80%. But when they actually noted down through the checklist, they found that less than 6 ml per kg tidal volume is being given only to the 17% of the people. So that is how you found out the truth. Not just perceiving that I am doing something good or bad, but actually trying to find out the truth by way of an audit. So that is how it is to be done. Second publication is in 2006 from the New England Journal of Medicine. It is a Peter Provenance study about the catheter-related bloodstream infection, and they placed 5 things in the checklist: appropriate hand hygiene, chlorhexidine for skin, full barrier precautions for CVC placement, subclavian to be the preferred site, and removing the unnecessary lines as soon as possible. And what they found, the changes in the incidence rate ratios of catheter-related bloodstream infection from the baseline, that is the study before they started doing the program, and then followed it up for the 18 months. And what they found, that catheter-related bloodstream infection as a base point, the rate ratio was 1, which is the control. Just in the study period itself, it decreased by around 24%, and then over a period of time it kept on decreasing. So CRPSI at the end of 16 to 18 months decreased to as much as 66%, and that is a good achievement. So we need to conduct the audit finally, that how good our program has been, or how well the program has been implemented. Regarding the information, as I have said, that there has to be a handover takeover. Howsoever small the checklist is there, but that checklist is going to help. Handover takeover can be with amongst the doctors, among the nurses, but that should be there in the placement. And this is the benefit that we get. So this is a kind of proof I want to put before you, that these are beneficial things. And this was published in 2009 in the Journal of Trauma. And here this is about the loss of the clinical data in the ICU. They initially did not have any written handover takeover program, then they implemented that program, and then they again conducted the study. And what they found is that the loss of the data was very heavy with regard to the lab results. It was as heavy as 36.1%, which was decreased to 4.5% after the intervention. So is happening about the regularity or about the antibiotics or cultures or medicines, whether something is lost or not, nutrition, ventilation, other things, tubes, CVPs and IVs, etc. and consults also. they were even losing the consults also to as high as 19.1%. A consult was done, then the next day nobody is knowing what is the result of that consultation. So overall they found that there was a loss of the information to the tune of around 20.1%, which was decreased to 3.6% after putting this checklist into place, that is the written handover takeover. So this is the benefit what we get. Then finally, if we are getting some results out of the audit that we do before the intervention and after the intervention, then how we are going to interpret that data. So I would say that quality indicator should prompt to have a deeper look and for the details into the results. An example would be the SMR, or the standardized mortality ratio. So suppose you found that the observed mortality is 30% and expected is 30, SMR is 1, then probably you're not probably much worried about. So it's true, but the second example, if the mortality is 10% expected as well as it is observed also 10%, but if the ISMR is going to 1.5, you are worried about, because expected mortality is 20 and your observed mortality in the ICU is 30%, then that would be worrisome. Then if something is worrisome in our sort of results, then we have to analyze that. So for the SMR, I can just give you an example that SMR analysis would have to be extended further, because SMR can be influenced by the case mix, lead time bias, ICU performance, post-ICU care and the score performance itself. So we have to analyze various factors which can influence the SMR, and then further on we have to have sub-analysis of our mortality, which can be cause specific, like when the sort of the patients, some complications that they are developing during the intensive care, like WAP, CRBSI, or some major error has taken place, some major complication has taken place. So cause specific death rate can be discussed, that can be found out, or we can look into the case fatality rates with the particular cohort. So it can be trauma cohort, burn cohort, acute MI cohort, stroke cohort, and things like that. So we can look into the specifics of the death rates in each group. So basically the quality indicator program will go through a complete cycle. First we have to develop some quality indicators for our own self, and depending upon the sense of urgency, the quality indicators would be entering into our registry. For that registry, first we have to do the raw data analysis or the pre-intervention data analysis, what is the status. Then we interpret the conclusions of that raw data. Then we put in place some quality improvement plan, and that plan can be 1 month, that can be 15 days or 3 months, whatever it is. Once that plan has been fully implemented, then we do the post sort of intervention study, and that gives that is the kind of feedback audit sort of thing, and then we further decide upon that what is to be done with that quality indicator. If some improvement has been achieved, then how to continue with those kind of sort of checklist, or if the improvement has not taken place, then again we have to have a relook into the system. So it is a kind of PDCA cycle which is well known into the circles of the industry, that is the plan, do, check and act. So this is all about the quality improvement, but before I finish about the quality, I will definitely say that it requires a lot of willpower, commitment, time and energy. But the benefit is definitely achieved, because if we do not put the quality improvement programs in the ICU, then on day-to-day basis we have to do a lot of firefighting, and we are basically sort of wasting our energy into that. So this guy is, he can be as a cartoon, I'd not like to, but it can be any ICU leader who is saying that I have so much of work on day-to-day basis, I have no time to invest on the quality improvement programs. But the truth is that if the fire safety things are there in place, probably you are doing something better. So the safety and quality initiatives should be in place in the ICU. Now briefly I will touch upon with the safety. As I have earlier said, that safety is part and parcel of the quality program. So a lot of aspects of the safety is already covered into my previous slides. But just to tell you briefly something about safety. Safety cannot be measured directly. So safety issues are to be measured through the shadows of safety. And these shadows are basically errors, adverse events and the harms. Now it would be a little waste of time if I go into the definitions or grand definitions of these things. we know what the errors are, we know what the adverse events are, and what the harms means. So basically, these are to be studied. These aspects are to be studied in a particular ICU if you want to study the safety in our ICU. While the ICU remains a fertile ground for the breach in safety, the cartoon depicts the nurse, about the inner oomph of a nurse, how many things a nurse is doing over there. So I'll briefly say that because the complex ICU is basically an area where the care is very complex, there are multiple tasks that are to be done, there are large number of treatment activities which can lead to a greater risk of overlooking any critical physical finding, any critical important laboratory test, or any critical radiological abnormality that we may miss. And sometimes too many caregivers may also create a problem. There can be conflict of opinions, there can be conflict in the treatment orders also. Then usually in the ICU, the dominant sort of psychological scenario is that people are very stressed at times, and there can be overworked staff and fatigue also as a cause of breach in safety. And finally, but not the least, but the cost and the resource constraints can also be there in the ICU as a cause of breach in safety. So here is in cartoon where somebody is reading, a patient is reading that the rate of medical errors are stunningly high in the hospitals, and that the next patient, who is a male patient, is saying that explains my hysterectomy. But let the cartoon be a cartoon, but that is how the errors are being taken by the society as far as we are concerned. Here, with regard to the safety, I would like to put one more word, because it usually doesn't appear very well into the literature of safety, but to my mind, delay in care is always leading to the negative outcome. So treatment must begin in the golden hour of the silver day for any disease, for any patient with any kind of criticality. And delay, I would say that delay is a kind of error that should be looked into. So the delay should also be although it has not been included into the definitions of or as a shadows of the safety, but that should be taken as a part of safety program, because delay is deadly in the ICU. So classification schema there can be errors, we know, but I am just putting them into the perspective that there can be the diagnostic errors, treatment errors, nosocomial infection related errors, procedural errors, or there can be some prophylactic errors that we are not able to do. So errors can be into the classification system again, like we spoke about the quality indicators. And this is just an example, and before I come to the concluding slides, this is an example from one of the ICU published in 2005. So just to put due emphasis on the incidence of adverse events and the errors that may take place in the ICU. And what they found in this publication, that 81 per 1000 patient days were the reporting of the adverse events. 13% of they were life-threatening or fatal. And most important point is that 45% of the adverse events were preventable, and that is very important thing. Coming to the seriousness of the adverse events, 70% of the patients in the ICU had serious adverse events. Coming to the errors, they found that almost 1.7 errors per patient per day is a very usual phenomenon in the ICU. And 29% of these errors had the potential to cause significant harm, and 11% was potentially life-threatening. So simple checklists can do wonders. I will not say only checklists, but I will just come upon that causes of errors and the suggested solutions. It is not only one sort of solution will not fit into all kind of errors that we want to address. So from the left I will move to the right as causes, and then there is a suggested solution for that. Causes of the errors can be because of the information overload that we can check through the smart alarms if we have that much of money, if we are investing into the information and communication technology in the ICU. Second can be that there can be complex processes which are poorly designed. The care process has been poorly designed. Now that can be handled certainly through the checklist. We can change our processes. There can be wrong incentives for the people who are working in ICU. That certainly we can address that, and we can make the incentives for the patient-centered care. There can be inadequate structure and staffing that we can address by the structural changes or staffing changes. Then there can be problems because of the ergonomics, either organizational, cognitive or physical, that we have to address through the decision support systems. Again, it is an investment in the information and communication technology. Some fragmented care is there, some provider-centered care is there. It is not the patient-centered care that can be handled through the dashboards. So these are the suggestions which were published in 2012 in the critical care, and we may take some lessons from this publication. So I will briefly touch upon the information and communication technology in the ICU. Some of the reports say that the sickest of our patients might generate 3,000 plus data points per day. One patient can generate. Now we can lose this data, we can miss some good information from this data. Obviously for that ICT is going to be of great help, and that includes not just the monitoring, but it is over and above the routine monitoring. That is having the electronic medical record system, smart alert systems, computerized physician order entry, clinical decision support systems. And then finally we must, for anything and everything that is software, we must have the data mining or data analysis software. So with that kind of ICT in place, there would be a data cloud that will extract the high value data, and that will be then converted into the information packages, and then the holistic picture of the entire ICU will emerge before us. So the ICT means data collection, data retrieval and data analysis for our own help. Safety generally means multiple defenses, multiple barriers and multiple safeguards, and unless those multiple defenses, barriers and safeguards are breached, usually the hazard should not lead to the loss. So this is the Swiss cheese model which was proposed by the James Reason, who published that book, that is the to err is the human. He is the same person, and perhaps we have to learn that we have to build our defenses and barriers and safeguards in such a manner that the hazard, that these holes are not falling in one line, and then the hazard is really not resulting into the loss. So though that is what our action plan is. Now what can be the actions that we have to undertake with regard to the safety? First and foremost thing is that there has to be committed leadership who definitely acknowledges one thing, that error is inevitable. Then there are certain prevention programs that are in place in the form of training, organizational changes or simulation programs. Early recognition of the error should be the fundamental thing in the ICU, and reporting must be 100%. If at all we want to work on the safety programs, implementation of the corrective actions should be widely published, and there should be a sort of mindset of continuous learning from our own errors, not the blame games. We should have resilience, we should have good work culture and climate. That is the basic necessities or actions that we can undertake to promote the safety in our ICU. So approach to safety and quality can be, one is that please avoid the non-evidence based medicine in the ICU. That medicine can be eloquence based, nervousness based, confidence or overconfidence based or eminence based, but that ultimately is not going to benefit the patient. It may lead to some tutu mama, but it's not going to benefit the patient. So really we have to shun away from those kind of practices, and we have to adhere to the evidence based medicine of our ICU. Second is the bundling of care that has become very popular once it was proposed by the Institute of Health Care Improvement, and it is almost these 4 bundles are almost approved by all the critical care organizations across the world. They are the ventilator bundle, central line bundle, sepsis resuscitation bundle and sepsis management bundle. So at least these 4 things must be there in our ICU, and we can have a checklist for that. Coming to the error prevention strategies, the old notion versus the new notion. The old notion about the error was that it was because of the negligent behavior of a human being, and it is just a human error and nothing else. Beyond that, there was no perception about the errors. It is basically a gift of these 2 industries. One is the aviation industry, and second is the nuclear reactor for the energy generation, that industry. They have inculcated the a sort of culture of safety into the systems. And from there we brought certain principles about the error prevention. And they tell, they are the industries which basically taught us that true determinants of safety lies into the system, that is the work culture and the climate itself. And regarding the people, only thing one can say is that though we cannot change the human condition, but we can change the conditions under which the humans work. So that is one thing which we have to keep in our mind. So the person-centric approach must be avoided. It is, we have to just follow the system-centric approach as far as the errors are concerned. And the system-centric approach begins with the premise that anything can and will go wrong in the ICU. Don't expect humans to perform perfectly all the time. Do design the systems accordingly in a proactive manner, and do have a collective preoccupation with the possibility of failure. So we should adhere to the system-centric approach as far as the errors are concerned. Then we have to change our mindset, then we have to change our vocabulary also, that errors are not taken as a human error, they are taken as accident and failure. The root cause analysis is not the need of the hour, then it can be multi-causal, and then multi-causal analysis should be in place. We should not investigate some error. Investigate is a police word. We should analyze and study the error. We should not have any judgment based on any particular kind of error reporting. We should be learning from that kind of reporting system. We should not bring the blame and fault kind of system into, it should be a blameless system, and any error should not be just taken an isolated event, it should be taken as a systems event. It is part of the system, then system has to address that error, and then we should not finally be adhering to any punitive or retaliatory actions against those who commit some kind of error, but we just make those people, we must tell those people that you are accountable people and you should do perform well. So it looks very odd at the superficial level, it looks very odd that what kind of leadership we should provide in the ICU to implement a change in the culture. It looks counterintuitive, but that is how it is. So what an ICU leader should not do, they should not indulge into telling and selling. They should be great listener and they should be great amplifier to the information. They should not push the people to change, rather than they should create a pull for the change. They should have enough leadership skills for that. They should not try to motivate or empower others, rather than they should be having a culture of discovering and releasing the passion and energy into the system. There I would like to say that trying to motivate or empower people by some kind of force, I would like to use a Hindi proverb that Sahas pake so mitha hove, which means it should grow naturally into the system, that the error prevention things, etc., they should not be pushed, and then we should not have the thinking your way to the new actions, rather than we should be acting your way to the new thinking process. So take home message mine would be that anybody who is interested into the quality and safety must go through at least these 4 kind of publications. One by the James Reason, to add is the human, second is the crossing the quality charge by the Institute of Medicine, published in 2001. Other came in 2005 as a complete critical care clinic devoted to the safety in critical care medicine, and then another critical care clinic was devoted to the quality, that was published in 2013. So this is the literature from where I have brought most of the information to you. And then what patient safety is and is not, it is not what most of us were thinking about 10 years ago. It is not what we have always done in our life. It is the most significant change in the healthcare system in over a century that can take place. It is a new, very new applied science that we have to learn very carefully, and it has potential to change the face of the modern healthcare for times to come. And ultimate challenge in that process would be that in the health system, the challenge is to change the environment from one of crisis and blame to that of learning and improvement, as I have told earlier. And regarding the team, we have to have a good teamwork in the ICU, but team is not just the number of people, because too many people can spoil the broth also. So team means that T for together, then everyone achieves more. That is what the team means. And when we work with that teamwork, as Michael Jordan has once told, that talent wins games, but teamwork and the intelligence wins the championship. So with that, I would like to finalize my topic, give my final slides. We have to really finally accept the truth that most of the problems are found in processes and not in the people. That we have to believe, and with that belief we have to enter into the quality and the safety programs in our ICU. And finally, for the leader or for anybody who is discussing the problems in the ICU, and they should try to have put those kind of solutions which are sort of having some kind of rooted in the value system, which has got a long life. You have to just give little of water and manure to that kind of thought process, and that blooming will continue throughout the times. But the short term or ad hoc sort of solutions probably is not going to be of much value for the safety and quality program. So we must cross the quality chasm. That is a very sincere challenge, and we must strive for humane, safe and effective intensive care. One may say in the words of Vivekananda that arise healers, awake and sleep not till the system gets rectified to the benefit of the suffering humanity. And please remember, medicine is an art based on science. So art is that which makes another stay basically, and medicine then must try and make the patient stay. With that I would like to conclude. Thank you very much.
Thank you, sir, for the excellent eye-opening talk. I'm sure delegates must be having so many questions and comments, so I invite comments regarding the talk. I myself have a question, sir. Can you explain this SMR, standardized mortality ratio? How to do that in ICU? What to do with that?
No, that is nothing. That is simplified. You choose either of those scores, the severity scores. Either you choose the Apache or you choose a MODS, and the expected mortality will be coming through those through that data. So on admission, Apache score of every patient is to be taken. Then we have to sort of find out the median of that Apache score. Say 1 year, say 400 patients. So 1 year period, 400 patients, the median Apache has been found. Then we should come to, that directly gives you the expected mortality against that median Apache. So that is, those things are available into the literature itself. You don't have to do much work. Only thing is that once you found out that your observed mortality that you have found based on your own Apache or based on your own MODS scale, what the standard literature is suggesting that as the expected mortality with that Apache score, with that MODS score. If the difference is there, then you are worried. If the SMR is beyond 1, then you are worried. If it is 2, you are more worried. If it is 3, you are extremely worried. That is what I am trying to say. So it has to be based on the Apache scoring, ICU admission Apache, or perhaps MODS is also having the similar kind of which can be linked with the expected mortality findings. So that international data we have to go by. But again, I like to put forth that SMR, even if you found that your SMR is 1.5, you have to finally give a further analysis to that why it is happening in the ICU. Suppose VAP is very high and that is the cause. Then your primary area is you address the VAP. If your VAP incidence rate is going beyond the limits, then VAP is to be addressed because that is causing the high mortality. If the catheter-related stream infection is very high, that is perhaps the cause of mortality. If we are having very sick ARDS patients and all of them are dying, we have to look into the lung protective mechanical ventilation, whether we are able to follow that. I don't know what is good and what is I mean, superiority and inferiority I do not know, but I consider that if a process is there, say one particular guideline is there, say lung protective mechanical ventilation, 3 things that we have to follow, something like low tidal volume, P plate less than something, and then stress index will also come into that in the future. So suppose 3 things I have to note down for every patient. I think if I am adhering 100% to the guidelines, I am doing the best thing. So irrespective of the outcome, irrespective of the mortality, at least I am satisfied. So my favorite is to have the checklist for the processes. Outcome, if it is bad, then anyway we will try to analyze, but my preference is for the process and not for the outcomes, at least at the beginning level.
I'll just mention about the outcome studies. Whenever we start implementing the quality safety program, and most of the people, we become too enthusiastic and start applying the outcome measures to individual patients. That's the greatest error that we do. All outcome measures must be collated over a period of time or a bunch of patients, and you see the outcome of your ICU, not individual patients. It would be inaccurate if you start applying individually.
Do we have some Indian data or Indian study to guide us?
I don't think so. We have collected that kind of an information, but this outcome measures we benchmark against the United States.
No, we don't have. May it be glycemic control, may it be ARDS management, may it be WAP prevention strategies, may it be CRBSI prevention strategies. It is all from the international published guidelines. It's hard. I don't find that we have anything specific to the country.
You have highlighted, sir, that safety and quality is important, but India, like country, where we are dealing with the vast kind of patient and vast kind of the settings. So you have rightly said that the target setting and the auditing at regular interval will be good for the future for any ICU. But since you have set a lot of indicators.
So I told you, like, we have chosen the fast hug and faith. We are just working on those 10 or 11 sort of points on a regular basis. We don't have any other checklist right now. But we can introduce, that's what I'm saying, that how much energy and how much willpower you have.
Any Indian study, any good study will guide us.
There is no study, but you have to start taking this step now. Take this final step now. And the advice is always start small.
Yeah, I think so. Later on you can expand upon.
Sir, one thing, it is a little bit different, but just I want to know which predictive factor is that should be followed in our setup, especially regarding Apache and so many modes, and there are so many scores. So I just want to know which one is the better one, and which one is ideal for.
I don't think there would be anything ideal. And most important thing about, and all these scores are there, that the derivation data of all these scores is from a Western setup. Do you believe that or no?
Yes.
All the derivation data comes from the West. Now, first and foremost thing that we may or may not be having the similar situation in our ICU. So I am even doubtful that. That's why I said that I am not interested in the outcomes, particularly the mortality.
Sir, I just want to know in your setup what
Apache 2. Apache 2. For your final answer from my side, Apache 2.
Oh.
Yeah. Thank you.
So thank you very much, sir.
Thank you.
This session is closed.